Good evening. My name is Roxanne Chabot from RBC Consultants. Welcome to another SkinChat webinar. This evening, we are going to be talking about adult acne, nuances in treatment, and the role of barrier-restoring adjunctive skincare. Our speakers this evening are Dr. Hilary Baldwin, who is at the Acne Treatment and Research Center in Rutgers Robert Wood Johnson Medical Center in New York. Also, Dr. Ted Lane, who's board-certified dermatologist, chief medical officer at Sonova Dermatology, and executive director and principal investigator at the Austin Institute for Clinical Research. As well as Dr. Heather Woolery-Lloyd, who's director of Skin of Color Division at the Dr. Philip Frost Department of Dermatology and Cutaneous Surgery, University of Miami, Miller School of Medicine. We'd like to thank our sponsor, CeraVe, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the dial-in information will be displayed. If you're having technical issues or if you would like to submit a question to our faculty, please submit the question using the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will be emailed to you within 1 to 2 days. We'd greatly appreciate it if you could fill it in and send it back to us. Within 1 to 2 days of the webinar, a certificate will also be sent to you and the recording of the webinar will be emailed to you. Again, if you want to submit any questions to our faculty, please submit your questions using the question chat pane on the right-hand side of your screen. And I wrote a little note there so you can see exactly where you need to write your questions. So without further ado, I will pass the floor virtually to Dr. Hilary Baldwin.
Well, thank you so much, Roxanne. It's such a pleasure to be here tonight. And let's see if I did this right and can go to the next slide. Nothing happening yet.
Just click in the middle. Yeah, you got it.
Okay. All right. So it's my pleasure to be the lead-off speaker tonight. So I get to talk about the objectives of tonight's presentation. We're going to discuss the role of skin barrier integrity, specifically in the adult acne patient population. We're going to discuss the clinical significance of both cleansers and moisturizers as adjunctive therapy for the treatment of these patients with adult acne. And finally, explore the specific ingredients present in moisturizers and cleansers that help us to take care of our patients with adult acne. So let's start with a polling question. Adult acne in adult women is, and go ahead and select one, even more common than acne in teenage years, most often seen in the U-zone distribution, less common than acne in adult males, often associated with endocrinopathy, and uniquely psychologically impactful. I'm going to take a few moments to wait for answers. So, you know, in my practice, I see probably more than 50% of my patient population is adult females. And I see them as, my answer for this question would be uniquely psychologically impacted. They are, there we go. Yes, and you agree. They seem to be more disturbed by their acne than their teenage counterparts. And I think that's because teenagers, you know, everybody looks the same, right? All of their friends have pimples, so they're not alone, whereas the adult female acne patient is alone in her experience. I lost the answers here, but the other answers you'll see the, thank you. You'll see the answer to in a moment. It's not more common than it is in teenagers. It's very common, but not more common. Yes, it is commonly seen in the U-zone, but actually acne all over the face is a more common presentation. It is less common in males than it is in females, and it is not usually associated with an endocrinopathy. So let's go ahead and talk a little bit more about acne in the adult patient. So last year, about 10 of us got together to discuss nuances in skincare in our adult acne patients, specifically our female acne patients. And we came to several conclusions, which included that current acne guidelines lack information on adult acne, related skin barrier changes, management, and maintenance using adjunctive skincare. And at the time, we were talking about the 2016 guidelines. Now, as you're well aware, the 2024 guidelines have come out, and they too are lacking in any kind of good consult in terms of quality skincare. And we also agreed that integrating quality cleansers and moisturizers as an adjunct to prescription and non-prescription therapies maximize regimen efficacy, not just because the patient is now able to use the medications that previously perhaps caused some tolerability issues. So what we did before this meeting started was to perform a literature review, and the search question revolved around what do we know in the literature about skin barrier integrity, specifically in the adult patient population. We've seen many studies and many expert guidelines on the treatment of pediatric patients, but not so much in the adult female. And what about the role of specific quality skincare like ceramide containing skincare as either monotherapy to make our acne patients better, or as adjunct to prescription, topical, and systemic medications? So the search was done. You can see the search terms on the left had to do with acne itself, and the search terms on the right, acne and the use of adjunctive skincare. And after filtering for the English language and looking at 2010 to the present time, in humans only, of course, we found 42 different papers that we evaluated. And of the 42, 10 were clinical studies, and you can see of those 3 were randomized controlled trials. And on the right, there were 32 review papers. And looking specifically at the systematic review, the meta-analyses, and the guidelines, we moved forward. So we noted that there were 8 guidelines, analyses, and systematic reviews. And of those 8, only 4 discussed skincare as either a monotherapy or as an adjunctive therapy. And you probably wouldn't be surprised to hear that 3 of the 4 came from our European colleagues, who are far ahead of us in terms of skincare in general and skincare in our acne patients in particular. They refer to them as dermocosmetics and talk about their use as monotherapy as well as adjunctive. So we're kind of behind the 8 ball here in that regard. And of the 10 clinical studies, none of them discussed skincare, specifically in adult acne. So this was an unmet need, something that we wanted to talk about in more detail. So in that poster that I just showed you that we presented this February, at the South Beach Symposium, we came up with 7 different consensus statements, and I have the privilege of discussing the first 3 tonight, and my colleagues will do the remainder. So statement number 1 was that while most common during adolescence, acne also affects a substantial number of adults, particularly women. So when we look at all of the data, we see that acne, of course, is the most common skin disease in the United States, affecting up to 50 million Americans, virtually every teenager. The only question is, how bad is it going to be, right? Almost 100% of teenagers have some degree of acne, but it also affects many adults, particularly women. So we see a high prevalence and incidence in women compared to men, especially after the age of 25, which I personally consider the onset of adult female acne. In one study back in 2012, looking at almost 3,000 women ages 10 to 70, they found that almost half of them in their 20s, a third in their 30s, and a quarter in their 40s have clinical acne. Some of them, the bulk of them, had continuous acne straight through from their teenage years, more so than those who had acne occurring for the very first time in their adult years, and more so than those having their second experience with the delightful disorder. So they had it, it went away, and it came back. In surveys of 26 to 44-year-old women, we've seen over the course of the last decade or so an increase in the total adult female acne cases seen in our practices. It's unclear if this increase in prevalence is actually real. Is acne increasing in the adult female population, or is this a presentation bias? It's possible that adults have just become less tolerant of the condition. It's splattered all over the internet, after all. And also we've got social media to contend with. So perhaps it's increasing because adult women have decided that they simply can't walk around with a face full of acne. And they figure now that it's a disorder that can be treated, because they hear about how acne medications nowadays are so much better than what existed when they were teenagers. In any event, it's costing an awful lot. The data point that I have here is back to 2013, where the costs associated with treatment and lost productivity was $1.2 billion. So everyone is suffering along the way, not just our patients. So statement number 2 was that compared to adolescent acne, adult acne may present with more lesions on the lower half of the face, in other words, the U zone. And in that kind of acne, comedones are very uncommon. Also, we stated that adult acne patients do not typically present with an endocrinopathy. So features of acne in adult women is that it's usually morphologically similar to teenage acne. So it's usually papules and comedones all over the face, not just limited to the U zone. However, it's unique to have acne in the U zone, and this occurs in adult females only. So the most common is all over the face, but if you see it in the U zone, it's always going to be in an adult female. And in that case, there are very few comedones seen. The last statement that I'm going to go over is that acne patients may experience cosmetically disfiguring sequelae, such as erythema, dyschromia, and scarring. Especially when severe, acne may lead to negative emotions, such as embarrassment and self-consciousness, particularly, as I said before, in our adult female population. So adult female patients have been shown to have actually a higher incidence of erythema, dyschromia, and scarring than their younger counterparts. And in one French study, half of the adult female acne patients reported dyschromia and scars. More than 90% said they manipulated their lesions, not surprisingly, and only 22% bothered to seek medical assistance. And what kind of consequences does this have? Well, of course, it has a great psychological impact associated with lowered self-esteem, anxiety, and depression, and can produce a whole host of negative emotions. Socially, this can be impactful as well, decreasing the likelihood that the patient is actually going to leave the house, perhaps some embarrassment in the workplace, desiring not to have public presentations, for example, in work. And we've also seen many surveys that show that the public is judging women with acne and thinking all sorts of negative things about them, resulting in increased unemployment rates in those with severe acne. And finally, of course, the physical impact, as this can lead to acne scars, which further negatively affect the quality of life and can last a lifetime. I suggest to all of you an article by Allison Layton back in 2010 called Scarred for Life. And in this paper, she demonstrated that even once acne has gone away completely and there is no physical scarring, adult women experience psychological scarring that persists, almost like PTSD, when they think about what it was like to have acne as an adult woman in today's society. So these patients are really experiencing a great deal of emotional discomfort. So in preparation for the talks that follow, let's just very briefly go over the pathophysiology and what's new, what do we know now about specifically adult female acne, because we know less about that, of course, than we do about teenage acne. We think that the pathophysiology is similar to that of the teenager, namely the 4 pillars of acne pathophysiology: increased sebum, follicular hyperkeratinization, colonization with C. acnes, and inflammation resulting from all of that. But we've tended over the years to call the kind of acne that occurs in the adult female patient hormonal acne. All acne is hormonal, right? So we have to come up with a better word than that, or just call it adult female acne and be willing to admit that there are things that we don't know about that kind of acne that may be different from the pathophysiology that we see in the teenager, as we'll go over in a moment. So let's take these one at a time and start with hyperkeratinization. Don't worry, I'm not going to go over this entire cartoon. I just want to make the point that this is very complicated, much more complicated than I think of when I think of follicular hyperkeratinization. It occurs in the follicular infundibulum, leading to stickiness of the laminated corneocytes. But there's numerous aberrations in filaggrin and keratins and cytokines within the pilosebaceous unit, all of which can be summed up in the new term comedone switch. And what comedone switch means is that not all follicles in an acne patient are clogged. Not all of them are going to produce an acne lesion. Some of them look like absolutely normal, healthy, non-problematic follicles. And then some of them go on to create pimples. So what is that comedone switch? What happens to convert a healthy follicle into an acne follicle? And that answer is yet to be determined. What about C. acnes? We talk a lot about this. We've been talking about it for many, many years, but we actually don't know if C. acnes proliferation is a cause or a consequence of acne pathogenesis. We know that everyone as an adult has about the same number of C. acnes organisms living in our follicles. So those of us with acne don't have any more C. acnes than people without acne. What we think the difference is between those of us who do and those of us who don't is that we see a loss of diversity of the C. acnes phylotypes in patients with acne. So we have 3 phylotypes of acne, aptly named 1, 2, and 3. 3 is not associated with the follicle at all. 2 is associated with skin health, and 1, specifically the subtype or clade 1A1. So that's the one that's associated with acne. So the thought is that acne patients probably have a predominance with loss of diversity within the follicle of 1A1, whereas those without acne have predominantly type 2 or have a more uniform distribution of acne subtypes living within their follicle. So what we're talking about here is not the amount of C. acnes, it's a dysbiosis of the skin and specifically the follicular microbiome that plays a role in acne development staph epidermidis. And finally, we have the issue with sebum production. Acne clearly is associated with sebaceous, right? The androgens increase at puberty. That causes the sebaceous glands to suddenly wake up from their quiescence and start chugging out sebum. And the severity of acne correlates with the sebum excretion rate. C. acnes produces lipases, and so they're all in the same milieu in that comedone switched follicle, which can convert sebum into free fatty acids, which they use as food, but results in comedogenicis. And in patients with acne, free fatty acid levels are 50% higher than those found in individuals without acne. We've also, so the bottom line, of course, is no sebum, no acne. So if we can figure out a way to control sebum production, we can find a way perhaps to decrease acne itself. In the recent past, we've started to talk more about the fact that the sebaceous gland is its very own endocrine organ. When we talk about acne, we've been thinking about the adrenal gland for years, producing DHEA, which goes into the blood vessel, the ovaries producing testosterone, which goes into the blood, and then it arrives at the sebaceous gland where it does its nasty thing. But it turns out that that's not really quite the story, that the sebaceous gland takes and picks from the plasma what it needs to make androgens. Sebacites contain all 6 enzymes needed for androgenic amplification. So these androgens act in the very same cells where they are synthesized. So testosterone and DHEA arrive in the sebaceous gland, gets converted into DHT and some of the other even more androgenic molecules like androsterone glucuronide. So it's produced in the very same cells in which it's used. So it's not released into the circulation. So checking serum testosterone in adult female acne patients is an unreliable marker for total androgenic activity. So we keep saying that it's not an endocrinopathy in the adult female. It certainly isn't in the systemic circulation, but perhaps it is locally. Perhaps we're experiencing local peripheral hyperandrogenism or end organ hypersensitivity within the sebaceous gland. So it is an endocrinopathy, but it's all localized to the level of the sebaceous gland. So that's why we end up treating our patients with multiple different medications to take care of C. acnes and follicular hyperkeratinization and increased sebum production. And these medications, although very effective, can often irritate the skin and cause problems in that regard, such that the patients aren't able to use the very medications that stand the chance of making them better. So what can we do about that conundrum? Well, Ted's going to tell you all about that. I turn it over to you, Ted.
Okay, thank you, Hillary. As usual, I learn something every single time I listen to Dr. Baldwin talk. I learn something. Thank you so much. We're going to go to polling question number 2. Lipid peroxidation refers to the oxidation of which component of sebum? So I know that Dr. Baldwin didn't review this, but we will review it. So is it linoleic acid, squalene, ceramides, or filaggrin? This is interesting because, as Dr. Baldwin mentioned, there does seem to be a change in the sebum content for patients with acne versus patients without acne. And note that I did not put free fatty acids here as one of the answers. So we're not really talking about those, are we? Okay. That's great. We were very, very close. Squalene is actually the right answer. And so we were very, very close here between linoleic acid and squalene. Linoleic acid, of course, is very important, especially for the production of ceramides. It's a precursor for the production of ceramides. But squalene actually is the right answer in terms of lipid peroxidation that may lead to the inflammation of acne, as well as the immune reaction to C. acnes. Let's go to polling question number 2, or number 2, yeah. Okay, is this true or false? Ceramide-containing skincare increases endogenous production of ceramides. So it's simple, guys. True or false? Does ceramide in skincare act as a signaling molecule or as a signal for increased production of ceramides endogenously in our patients? And that's going to be important, and we're going to talk about why that's important in my section. Oh my gosh, almost 50-50. So the answer is actually true. Ceramide-containing skincare does signal an endogenous production of ceramides, making it even more important for our acne patients. All right, that was great. Okay, and now I think I get to take over, right, Roxanne?
Yep, just click in the middle of the screen.
Okay.
There you go.
Okay, great. So this is really timely for me. Today I saw a patient, a 37-year-old female, who came in after being on a few medications that I prescribed, along with that envelope of wonderful skincare. You know, I write down AM and PM regimens for all of my acne patients: the cleanser, the moisturizer, the sunscreen. I tell them exactly how to use it. And she came in and she had gone from IGA of 3 to 4, so moderate to severe, to an IGA of clear. She literally was clear and crying in the office, thanking me. And you know what was so nice was that she was able to use these 2 topicals, and I think I put her on spironolactone as well. And she really had done everything I asked her to do, and she had achieved the results that she wanted to. And it was just this amazing transformation. I know all of you listening have seen this as well, but it's just so heartwarming. I mean, what we can do for people, as Hillary mentioned, as Dr. Baldwin mentioned, you know, acne is a lifelong process. It affects them in a PTSD manner, especially scarring, even if they don't have acne or scarring visible in their adulthood. And so imagine as an adult to develop acne and then suddenly have all of that hit you at one time. It was really impactful to me, especially as I prepared for this talk. So statement number 4 of the consensus statement: acne is associated with inherent abnormalities in skin barrier function. Acne medications can induce additional changes that further disrupt epidermal function and the skin barrier. Look, it's not news to us that many of the medications that we have, especially the ingredients that we've had, I mean, benzoyl peroxide we've had now for 80 years, tretinoin we've had for 60 years. So, and those are the 2 real mainstays of acne therapy to this day, right? That we know that they can cause disruption of the barrier. And so if you have a condition in which transepidermal water loss is already an issue, and you add to that further barrier disruption, of course you're going to lead to epidermal inflammation, you're going to lead to redness, itching, all of the things that we think about with atopic dermatitis, quite frankly. So it's really important for us to focus on the barrier with our acne patients. So look, the issue with acne is that in that lipid lamellar bilayer, right, cholesterol, ceramides, free fatty acid, those are the 3 primary components of the epidermal barrier. There's a lack of ceramides there. The ceramide content is actually lower. So it's important for us to replace that anyway. But we also know that there's a problem in addition to the decreased concentration of ceramides in that lipid lamellar bilayer, the cornea sites are more sticky, right? That there's a problem with the hyperkeratinization, there's increased desmosomes, there's increased tonofilaments. All they want to do is stick with each other. And that leads to, of course, comedogenesis. Dr. Baldwin mentioned the comedone switch. But we don't know which follicles across the face have the microcomedone or not. Even with our dermatoscope, we can't see these microcomedones. And so we have to consider that the entire epidermal surface across the face, and in some patients, the chest and back, is acneic, right? And that's why we have to treat all of that surface all of the time. And then of course you've got this very thin-walled follicle which has, you know, increased inflammation. You've got these thick-walled Cutibacterium acnes, bacteria that are proliferating as well, and it can rupture. It's thin-walled, it can easily rupture, and then the contents leak out into the dermis. And what have you got then? More inflammation. So it's self-propagating as well because of the pathogenesis of the actual disease at the early stages, okay? And so we have to do something, therefore, to quickly affect the barrier function, to quickly restore that in order to, A, deal with the hyperkeratinization, but B, be able to hopefully stop the follicular rupture that leads to all the bad sequelae thereafter. Okay, so the compromises in skin barrier integrity on a functional level, we have increased sebum excretion, and the more sebum that's excreted corresponds to the greater the severity of acne. You know, your sebaceous glands are larger, there's subclinical inflammation. In other words, there is inflammation happening at the microcomedone aspect, but now I think we actually know that there's inflammation happening even prior to the formation of the microcomedone. And that's what I was talking about in regards to lipid peroxidation. When you have that oxidation primarily of squalene, that can lead to inflammation even prior to the formation of the microcomedone. So again, you just don't know what part of the face is going to develop clinical acne, but so much of unknown subclinical acne or inflammation is happening, we have to treat all of it, okay? And that means we have to treat all of it, including skincare that can help repair the barrier. Then you've got the ultrastructural changes in skin barrier integrity. You've got increased filaggrin expression. Filaggrin, filament aggregator, that's filaggrin, okay? So what does it do? It aggregates the filament. Well, That kind of corresponds to hyperkeratinization, doesn't it? Okay, that makes sense. A decrease in free fatty acids that Dr. Baldwin mentioned, a decrease in linoleic acid, decrease in free sphingosine, and by the way, a decrease in total ceramides. Not surprising, since linoleic acid, sphingosine, we have the ingredients for ceramides are decreased as well. So we have to replace the ceramides. If we're talking about the barrier, guys, we have to replace the ceramides as well. So subclinical inflammation, as we mentioned, is present early in the emergence of acne lesion development. Even if we don't see hyperkeratinization, i.e. the comedone, the sebum production is higher, the size of the sebaceous glands is larger compared with age-matched controls with healthy skin, and inherent structural or functional epidermal barrier disorders in acne need to be addressed therapeutically. If you're going to start an acne medication that can alter the epidermal properties, you better start it with really good functional skincare as well. So follicular keratinization alterations, as I mentioned, lead to the microcomedone formation as well as, down the road from there. Okay, and keratinization, remember, is the way to think about that is that the corneocytes, the dead keratinocytes are so sticky, they just want to be with each other, and that's what they don't separate, right? They don't release, and unfortunately that's what causes the microcomedone and then the comedone. Increase in filaggrin expression, filament aggregator, makes sense why that would be corresponding to the microcomedone, but it's not known if that is a primary or secondary event in acne. All right, so what are the acne treatments? As I mentioned before, we've got benzoyl peroxide, which is essentially an antimicrobial. It'll kill whatever it has on the skin. It doesn't necessarily kill just bacteria. It kills anything on the skin. So if you want to carpet bomb the entire microbiome, benzoyl peroxide is the way to go. Okay, then you've got topical retinoids, which of course, that's the whole retinization, right? Is the increase in transepidermal water loss as the retinoids change maturation and proliferation of the keratinocytes, and then oral isotretinoin, which essentially takes what I just said to the next level. Then you've got the increase in transepidermal water loss that is the result of disruption of the stratum corneum and the skin barrier, which really the way to think about that is a disruption in the lipid lamellar bilayer, which is what coats all those dead keratinocytes and what forms that barrier. It's the cement between the bricks of the barrier. And then the microbiome alterations, we're not really going to go into that, but oh my gosh, how important is the microbiome for acne? Okay. So mainstays of treatment include BPO and topical retinoids, antimicrobials as well. Of course, we are, as a specialty, trying to get away from systemic antimicrobials, which can lead to resistance and obliterate the gut microbiome. And we know there's a gut-skin connection. That's a whole nother story. Benzoyl peroxide mechanisms of action may inhibit bacterial growth and inflammation. That is true. It's chemiolytic as well. It's been shown to inhibit the production of C. acnes biofilms, super important. It has bactericidal and bacteriocytic effects on C. acnes, which are antimicrobials. And there are, of course, new quinolones, tetracyclines, macrolides, which have anti-inflammatory effects, can inhibit cytokines. And that's probably, really, that's why we're using our antibiotics is more for their anti-inflammatory effect than to kill the bacteria anyway, which is so difficult, especially with C. acnes. So what are the targets for the hyperkeratinization in acne? As I mentioned, retinoids regulate that keratinization in the infundibulum. Benzoyl peroxide has a comedolytic effect to kind of separate that comedone out of the follicular infundibulum. Again, we are trying to prevent follicular rupture. Now, we're trying to also decrease the expression of TLR2. So toll-like receptor 2 is a pattern recognition receptor, okay? Pattern recognition receptors are what connects the microbiome to your immune system. We talk about the microbiome as being a secondary immune system. Well, it has to somehow communicate with your innate immune system, right? And that's where these pattern recognition receptors, a toll-like receptor 2, for example, comes in. And what that does, it recognizes an alteration in the microbiome, and then it will then signal the immune system to bring in certain inflammatory cells. Okay, and so that's how so decreasing toll-like receptor 2 makes total sense if we're trying to decrease inflammation, and that's what topical retinoids and BPO does. And isotretinoin can also inhibit the hyperkeratosis in the infundibulum, as well as these toll-like receptors. Okay, what are the targets for sebogenesis in acne? Clascoterone, right, is a sebum inhibitor, okay, approved for acne patients 12 years and older. It is applied twice daily. We know from their phase 3 data that it can take some time to really see the effect on acne. So this is one of those medications where you kind of have to tell the patients, look, this is probably going to take a couple of months until this really kicks in and can help alleviate some of the acne burden. Isotretinoin inhibits sebum production as well, reduces the size of the sebaceous glands, we believe permanently in most people. Topical linoleic acid has been shown some efficacy in acne, no significant reduction in sebum, but you can imagine if you can change the composition of sebum, as I said, increase in squalene concentration in the acneic sebum seems to be pro-inflammatory via lipid peroxidation. If you're able to dilute that with, for example, with a linoleic acid, that may help. In addition, linoleic acid is a precursor to ceramide, so there is, there's some logic behind topical linoleic acid. Anti-androgens that are topical are effective against acne for obvious reasons. IGF-1, insulin growth factor 1 modulators have been reported as effective treatments for acne. As we know, insulin-like growth factor is one of the hormonal/paracrine effectors of acne severity as well. And then systemic anti-androgens are effective against acne. That's why we use spironolactone, oral contraceptive pills, for example, in order to alleviate the acne burden. Okay, I am very happy now to present a good friend and colleague, Dr. Willery Lloyd from Miami, to go through the remainder of our statements. Thank you, Heather.
Thank you. I agree with you, Ted. I'm learning from both of you, and I'm excited to move on with this talk about skincare. And I'm going to be talking about skincare, which is one of my favorite topics. But before we jump into that, we're going to do polling question number 4. And this question is an interesting one. So I think it's one of the most common questions I hear, which is, when using a retinoid, do you recommend that the adjunctive moisturizer be applied before the retinoid, after the retinoid, or it doesn't matter? So I'm really interested to hear everybody's response, because I sometimes think that this can be a hot topic, although it's something that seems like it's pretty straightforward. So I'm very, very curious to see what all of you think when it comes to moisturizers and retinoids. So what did we see here? Okay, so the majority said after, so 58% said after. And I will say, in my clinical practice, that's actually what I do. However, studies suggest that it really doesn't matter. And there have been studies that have looked at retinoids, but also other topical acne treatments, and applying a moisturizer before or after did not affect efficacy. So I love to see everybody's response. I actually do use the adjunctive moisturizer after the retinoid, but really studies suggest it doesn't matter. So let's move on and talk about skincare. And I'm going to move on to statement number 5, which states, once or twice daily application of fragrance-free, non-irritating, and non-comedogenic cleansers, moisturizers, and sunscreens may reduce adverse effects resulting from prescription oral and topical medications such as dryness, erythema, photosensitivity, and PIH. And of course, because most of my patients are skin of color, PIH is the #1 concern that my patients have when it comes to acne. Their quote-unquote acne scars are the dark marks, and skincare really can play a role, particularly sunscreen. So we're going to talk a little bit about skincare and acne. So in general, for our acne patients, we want the daily application of a fragrance-free, non-irritating, non-comedogenic cleanser, moisturizer, and sunscreen. And this can reduce those adverse events that we see with our acne treatments, like dryness and erythema and PIH, which is of importance, particularly in my patient population. Oftentimes my patients will say just a simple addition of sunscreen, even if I don't give them an agent to treat their pH, just adding sunscreen into their skincare routine when they have acne reduces the risk of those post-inflammatory pigment or those post-acne dark marks. So this is just generally what we do for all of our acne patients. Now, monotherapy, a lot of people, before they come to us, most women, actually adult women with acne, have used over 10 over-the-counter products before they come to us, and to, for prescription therapy. So very, very mild acne can be managed with skincare. So over-the-counter products, oil control products, and so forth. But most of us in practice are using skincare as an adjunct. Most of us, our patients are getting prescriptions, and skincare is an adjunct to our acne routines. So the reason why we need this adjunct, we heard from Dr. Lane that ingredients like benzoyl peroxide and retinoids are very drying, and they impair that skin barrier function. So adding in a really good moisturizer, a gentle cleanser, things that really help to restore that skin barrier are really helpful. And I'm going to show you some interesting data on that. And then maintenance is something that I think is quite interesting, because so many times our acne patients think, oh, my skin's better, I can stop everything. Oh, it's clear, I can stop. But actually, we know that's not the case. You absolutely have to do maintenance, both with prescriptions, but also with really good skincare. So skincare, the gentle cleansers, really effective moisturizers, pH-bound skincare, really important for maintaining healthy skin even after acne has cleared. So this is an interesting study that looked at two different groups. It was a 12-week study, and some of the patients got just a foaming wash twice a day, and the other got a pH balanced gentle foaming wash and a moisturizer. So one group got what many of our patients are typically doing, probably an over drying, highly surfactant based cleanser. And a lot of times acne patients don't want to use moisturizers, or think they don't want to use moisturizers because they think, oh, I'm breaking out and the moisturizer will make it worse. So this is like a very good real life study, because it compares something that is probably we see in our clinical practice to what we do when the patients come in and what we would prescribe. So the first graph that you can see here on the left, this is the baseline, and this is looking at transepidermal water loss. So the change in transepidermal water loss at baseline. So obviously, when these two groups were started on a prescription routine with adapalene 0.3% and benzoyl peroxide 2.5%, so a real heavy hitter when it comes to acne. I use this product a lot. That really can cause a significant amount of dryness. It's not unexpected that transepidermal loss went up. But you can see in the blue group, the subjects who got the gentle cleanser and a moisturizer, that increase in transepidermal water loss was not as high. You can see at week 4, the skin is starting to normalize, because remember, baseline is here at 0. And then you can already see at week 8, this is interesting. In the group that got a really good skincare routine with a gentle cleanser and a moisturizer, you can see that the actual transepidermal water loss gets better. So their skin is actually more hydrated at this point. And keep in mind, they're using this very potent prescription product with adapalene and benzoyl peroxide. And at week 8, even less transepidermal water loss from baseline. So this shows us the importance of skincare when it comes to acne treatments. When we're using really potent retinoids and really potent other prescription topicals like benzoyl peroxide, you can see how much of a difference a really good skincare can make. Here you can see not only did the barrier return to normal more quickly, but you actually had an improvement in the barrier at week 12. And when it came to reduction in erythema, this is not unexpected. The group that was on the skincare regimen with a gentle cleanser and moisturizer had less erythema, and also, of course, a reduction in scaling. So skincare is a really important part of my routine for my patients with acne, and all of my patients leave with a very carefully designed skincare regimen when I'm treating them for their acne. So statement 6 states, irrespective of the effect of a prescription acne product on skin barrier integrity, repair and support of the skin barrier should be a foundational goal of a skincare regimen in acne patients. This is such an important statement to me, because basically the statement is saying at baseline, our acne patients have a disrupted barrier. So even if we're not doing prescriptions, we still should be focused on that barrier. And although most of us do prescriptions, I think that skincare is important even if we don't use prescriptions in our patients. So When it comes to skincare, probably one of the biggest culprits of disrupting the barrier are cleansers. And cleansers typically have surfactants that solubilize and remove debris, oil, and makeup. But the biggest issue with surfactants is that some of them can irritate or disrupt the stratum corneum, causing erythema, dryness, and this skin barrier impairment. So the best way to approach an acne patient who might be using a stronger surfactant because they think they can scrub their acne off is to switch them over to a gentle facial cleanser and of course a moisturizer to improve their xerosis and their dry skin. So originally cleansers were soaps, which were very alkaline, and a high pH is associated with a disrupted skin barrier. And studies suggest that our acne patients at baseline, before they even are using these harsher cleansers, have a higher pH. So there's a study that looked at acne patients and looked at the pH on their skin, and across the board, acne patients had a higher pH than normal controls, which means at baseline, their skin barrier was disrupted. So when it comes to cleansing, it's really important to talk about using a gentle cleanser. And in my practice, and I think that, this consensus that we all worked on together, many of us use twice daily use of a gentle cleanser in patients with mild to moderate acne. In one study, it reduced acne lesion counts without damage to the skin barrier, and most importantly, without sebum overcompensation, because sometimes when people use a really harsh cleanser with harsh surfactants, the skin reacts by producing more sebum, and I've definitely seen patients complain of that. So cleansers and moisturizers are very important to support that epidermal barrier repair. And that's because we want our cleansers and moisturizers, but particularly the cleansers, to be pH balanced. That means within the normal pH of our skin's acid mantle between 4 and 6. Why? Because when we have a higher skin pH, that has been well demonstrated in acne patients, there's reduced epidermal barrier integrity, reduced antimicrobial defenses, and increased inflammation. So we do not want our acne patients to have a high skin pH. We really want to lower their pH. And then cleansers and moisturizers with ceramides and essential fatty acids that are pH balanced help to restore that epidermal barrier function, reduce transepidermal water loss like you saw in that study I just presented. They maintain a healthier pH for the skin and improve the antimicrobial defenses. So when you're thinking about moisturizers, what does the ideal moisturizer look like? So we want our ideal moisturizer to be safe, effective, and cost effective. And I'm really focused on cost effectiveness because our acne patients get multiple prescriptions with multiple copays, and then they have to go out and buy skincare. And so it's, I'm very cost sensitive for my patients, and I think cost is definitely important. We also want an ideal moisturizer to be additive, fragrance, and sensitizing agent free. We want it to be pleasant to use. It should optimize the optimal lipid and water content of the stratum corneum. But most importantly than anything, patients have to like their moisturizer. They have to like their skincare. If you think you prescribe the best thing on earth and the patient doesn't like it, it really doesn't matter. So patient satisfaction is really important. So when we talk about skincare, it does influence adherence to our prescription therapies. And the study looked at this and they found that patients scored common reasons for low adherence, so low compliance, with medication side effects like dry skin and irritation. So I talk to all of my patients and tell them this product could make you dry, this product can make you dry. If it does, decrease it to every other day. I give very specific instructions because I don't want them to say, what you gave me irritated my face and I had to stop everything. That's the last thing I want my patients to say. So I do talk a lot about the potential for irritation. And the factors in this study that improved adherence or compliance were use of moisturizers and gentle cleansers. Of course, if the product was clinically effective, and then patient knowledge of treatment. So I definitely think it's, even though we're busy and we're seeing, a high volume of patients as dermatologists, I do take time with my acne patients and I really go through their skincare regimen because I think it does predict compliance and predict how well they're going to do. Skin irritation and dryness leads to poor treatment compliance, and more simple regimens provide better outcomes. So when we're treating our patients with acne, definitely talk about skincare and talk about the side effects of their prescriptions and how skincare can really help with that. Sometimes when I give my patients their retinoid at night, I tell them the moisturizer is just as important as the retinoid because I really want them to use the moisturizer so they won't stop their retinoid because it's too drying. So this was another kind of consensus paper. It was looking at moisturizers as an adjunct to acne treatment. And the group reviewed the literature and then came up with some consensus statements. So those statements were that dry skin and irritation is an important reason for non-adherence. Skin barrier dysfunction can contribute to acne. Remember, acne patients have a higher pH, higher transepidermal water loss. Dry skin and irritation commonly results from our prescription therapies. Moisturizers can improve dryness and irritation from our acne treatments, improve adherence or compliance, and complement our prescription therapies. And moisturizers and cleansers should be considered in acne treated patients. And I think that's an absolute must. You know, I'm surprised that skincare, I'm surprised that we don't talk about skincare as much. And I think it's so important for us to have these talks that we're having today. So statement number 7 states, improving skin barrier function, which reduces skin irritation, may increase adherence to acne medications and thus clinical outcomes. And this is a very important slide to me because this is real clinical in the trenches advice that I think really helps for outcomes for your patients. So these are the pitfalls to acne treatment failures. So first of all, having a reluctant patient. So, and this really might be your teenager who really doesn't care. Some teenagers are, the parents are more care about the acne more than the teenagers. So the patient really has to want to use it. I always tell the teenagers who aren't getting better because they're not using their treatment, I say, you have to use it to get better. It doesn't get better when it's sitting on your shelf. You actually have to use it. A non-informative quick visit. Now, I know we're all busy and running out of time half of the time, but we really do need to, at least on that first visit, spend time with our acne patient. Too many treatments without a handout. So all of my patients get a handout, 3 or 4 steps in the morning, 3 or 4 steps at night. I hand it to the patient. I go through those 3 steps with them. And then a lot of patients will say, this is my homework. They'll tape it to their mirror and do that every night. Too strong of a treatment at onset, that's why we use retinoids every other night and then increase it every night as tolerated. Irritation without information, that's that patient education component. And of course, this illusion of the quick fix, which all of our patients think because of TV commercials that acne clears up in 2 days. And we all know it, it takes several weeks. So I set that expectation. You'll be a little bit better at 6 weeks. You'll be a little bit better at 4 weeks. You'll be even more better at 6 weeks. Hopefully you'll be getting close to clear at 12 weeks. So a well-tolerated, easy-to-use skincare routine ensures safety and simplifies our treatment and really optimizes compliance, which I think is so important for success in our acne patients. So studies show that acne-affected skin may be prone to irritation. We've really kind of gotten that point through. And our topical and systemic treatments can really aggravate that skin barrier. And so I really can't emphasize enough, at least in my practice and based on all of these consensus papers, how important skincare can be in having successful acne outcomes. So skincare really is a necessary part of an acne treatment regimen. You should use it for acne prevention. But for most of us, it's as an adjunct to our treatment and then for maintenance. They can't stop. And also don't forget sunscreen in all of your patients, but in particular in your skin of color patients, because it really helps with maintaining, clear skin and preventing the dark spots. The type of acne and the individual patient characteristics can help determine the appropriate skincare. So I don't give the same skincare to my adult acne patient that I do to my teenage acne patient. The adult acne patient might have slightly more dry skin. She might want something slightly more hydrating. So really tailor your skincare to your patients. And this consensus paper stated that dryness and irritation resulting from acne treatment could be improved with ceramide-containing cleansers and moisturizers to improve that treatment adherence. So what are some tips to avoid treatment failures? Stress the potential downsides of treatments. Don't downplay the dryness that people get from retinoids. I think we're all pretty good at that and patients are pretty educated on that. But I talk about benzoyl peroxide, which can also be drying. Stress a minimum of 6 to 12 weeks before improvement. So I'm a little more optimistic. I'll say you'll be a little bit better in 4 weeks, but even more better at 6 weeks, and then significantly better at 12 weeks. Place a treatment handout into the patient's hand. I've been doing that for the last 20 years. I think it's really effective. And don't have the patient return to clinic for at least 6 to 12 weeks. So our conclusions are that acne affects a substantial number of adults, particularly women. That's the vast majority of my practice. Compared to adolescent acne, adult acne does tend to be more inflammatory with involvement of the cheeks and the lower half of the face, and comedones are less common. Acne is associated with the skin barrier dysfunction. We've heard many studies to support that with increased transepidermal water loss. Treatment can exacerbate this dysfunction, and dry skin and irritation contribute to poor adherence, especially in our adult acne female patients who tend to be a little more dry. As an adjunct to treatment or standalone, pH-balanced cleansers and moisturizers can improve xerosis and irritation and acne outcomes, and ceramide-containing cleansers and moisturizers promote a healthy skin barrier function, reducing xerosis and irritation in our acne patients. Thank you.
So we have a couple of minutes for any questions that you would like to ask. Please write them in the question chat pane at the right-hand side of your screen. And also we'd like to thank again our supporter, CeraVe, for making this educational event possible. So the first question that we have, is it important to have all 3 ceramides in skincare, or will any ceramide do?
I'm happy to take that one. I think the benefit of using 3 separate ceramides, 1, 3, and 6, for example, is that, you know, ceramide 1 is really the conductor of the orchestra in terms of the ceramides in the skin. It tends to be the one ceramide that makes sure that the other ceramides are implemented appropriately within the ceramide hierarchy within the lipid-lamellar bilayer. So to me, it only makes sense to include the 3 ceramides versus, you know, just willy-nilly throwing a ceramide 3 or a ceramide 6, because they all play such an important function within the ceramide functionality of the bilayer.
And I'll add to that, you know, I love studies, and those 3 have been the most studied. So like when we're referencing different studies, particularly for acne, that combination is what has been studied. And so a lot of our conclusions are based on that combination.
Mm-hmm.
Another question, if pathogenesis of the disease is the same in all patients, why do only some women get adult female acne?
Oh boy, that's a great question. Who knows? Does anybody here know? It's
Well, I'll jump in. I'm going to give a little bit of lifestyle when it comes to that. I will say that you know, sometimes there's like this new concept. There was a paper that said acne is a metabolic disease of the pilosebaceous unit, and so I do think lifestyle plays a role for sure. And you know, we know that high sugar diets, high glycemic diets, we know that dairy and whey are associated with acne. So, you know, maybe there's a component of lifestyle that can contribute to why some women get acne and some don't. I can throw that in there.
That's certainly true. And also we have limited data, but we have some data that indicate that adult female acne begets adult female acne. So when mom has a bad issue with the adult female acne, her female children are more likely to experience that as well. But other than that, I don't think we really know. We certainly can't predict who's going to suffer from it and who is not.
Another question, do you think skincare influences post-inflammatory hyperpigmentation?
Oh, I'll definitely answer that. Absolutely, it does. Sunscreen alone, like I always give my patients something to treat the dark spots, always. And I also say, this is a very good clinical pearl. When you're writing a retinoid, say this will also help with your dark spots, because you have to reinforce to your patient that you're addressing their number 1 skin concern, which is the uneven skin tone and the dark spots. So I'll say this works on, you know, helping to reduce I don't go into that much detail, but I'll say this works on whiteheads and blackheads, this works on inflammatory lesions, and when I get to the retinoid, I'll say this also helps with your dark spots. But when it comes to sunscreen, that alone can reduce those post-inflammatory dark marks from acne. And then I usually do use something additional in the morning typically. And occasionally I'll do some spot treatment at night, but I will use products, adjunctive cosmeceuticals, to treat the dark spots.
Yeah, I think the hyperpigmentation is always interesting because the lesions themselves, of course, cause hyperpigmentation. But if we're too aggressive, so we want to get it under control as fast as possible. But if we're too aggressive, of course, now we have iatrogenic hyperpigmentation. So I like to be what I call cautiously aggressive, increasing the strength of the medication from the very start, but using these quality skincare products to control the irritation that it's inherently part of a more aggressive treatment plan, to try to get the patient under control as soon as we can, but not end up with this problem with iatrogenic hyperpigmentation and irritation.
Yeah, if I can jump in also, I think I agree with everything that's been said. I think just to reiterate, the importance of barrier repair for hyperpigmentation cannot be understated. If you look at all the acne trials that have been done on these topical products and you look at the vehicle arm, essentially the vehicle arm is the impact of barrier function on acne. And usually we see a 30 to 40% group of patients that achieve that IGA success of 0 or 1, and that is pretty consistent between trials. So don't forget barrier repair when it comes to PIH, because that will also affect the severity of the acne, to Dr. Baldwin's point. And so really, you can't just focus on there is pigment, I'm going to just focus on my hydroquinone or my lightener du jour. I really have to focus on barrier repair along with that if you're going to be successful.
I agree. I think like that's why that moisturizer at night, and another clinical pro, I'll tell my patients, this is just as important as the retinoid. If you don't use this moisturizer, you're going to get irritated and you can get post-inflammatory pigment. So really good moisturizers at night, I think also reduces that risk.
Yeah.
Well, that's all the time we have to spend together. We'd like to thank Dr. Heather Willery-Lloyd, Dr. Ted Lane, and Dr. Hilary Baldwin for a really interesting presentation on a very hot topic in dermatology. And we'd like to thank you all for joining us. So good night, everybody.
Good night.
Thank you.